Good evening, everyone. And as Jason said, thank you all for joining us tonight. I know there's a lot of things that everyone could be doing. I hope to make this interesting and interactive if people have questions. And the title, which you'll see of the presentation, is A New Look at an Old Procedure. Okay, so I do have a disclaimer. I am a recent consultant for BioPro Inc., but I'm going to try to make this presentation more educational and certainly unbiased. So my outline for this evening is just a brief touching on the history of the Hemi implant, alternatives, which you're all very familiar of, and I've seen a couple of familiar names on the attendees tonight. I did take some intra-op photos of a recent surgical procedure, which I'll share with you. A little bit of what I tell the patients as far as post-op expectations. Some of the benefits that I believe that you can offer your patients for doing this procedure. And along the way, I'm going to be talking about some tips and pearls and some things I recommend to make your outcomes the best. So the history, and this is provided by industry. It is a phalangeal-based product. It can be either non-porous and porous coated. There are 5 standard sizes for the first MPJ. Generally, you get cobalt chrome unless you know you have a patient with a metal sensitivity. You can order it in titanium, and I'll talk a little bit about that towards the end. There's also 9 sizes for lesser MPJs, and I've only done a handful of those in the past. The first implant was designed and implanted by Dr. Townley in 1952. Zimmer controlled the product for about 40 years, and then BioPro was founded by Dr. Townley in 1987. So there are many options for your patients with Hallux limitus or Hallux rigidus. We'll talk about some of them. I will say that foot surgery tends to have darling procedures for different procedures. Right now, I think you all know that there's a media blitz for a certain jig system for base procedures. I have patients come in with hammer toes, and they ask me if I can do this procedure on them for hammer toes. So this procedure, that the arthroplasty with Hemi, is not one of the trendy darling positions, but I think it has its place with the right patient selection. So myself, I have implanted about 150, a conservative estimate of the Hemi implants. I had about 100 at one hospital, and then I estimated the other hospital, but I'm sure it's 150 or greater. I had 2 posters, the last one in February at ACFAS, which was a 10-year follow-up. And from that, we found out that there was an 80% satisfaction rate. The patients would elect to have the procedure done again. And I've only taken up 3 of my own implants, and that's over a long period of time. On that poster, the patients were average of 64 years old. They were either between 9 and 11 years old. We had 15 of them, and their AOFAS score was 81.25. And just for reference, you can see the common grading system for Hallux limitus. I would say that certainly up to grade 2, you can use these implants, and you might argue that the case that I'm going to present is a grade 3, and she's doing extraordinarily well 2 weeks out. Here's the poster. So what can you do with a patient that walks in your door with Hallux limitus or rigidus? And I would say that that is a very common procedure, diagnosis, excuse me. And there are a variety of options. There's the standard Keller procedure, which has been around for a long time. There's a chylectomy or a cleanup. And total joint arthroplasty, where you address the pathology on the metatarsal side and the phalangeal side. And the reason I asterisk fusion is I would offer that that's one of the darling procedures now, especially with the industry blitz of one of the very common, well-advertised procedures that's out on the market now. Then there's the decompression, Youngswick or shortening, and for completion's sake, a stone procedure, removal of the entire or most of the first metatarsal head. I've actually done that on a few indicated patients. So here's some pictures of some of the options for Hallux limitus. Keller procedure without any implantation, two varieties of a double stemmed implant or two-component implant. Bottom left corner is a simple chilectomy. The cartoon in the middle bottom is decompression or shortening osteotomy. And then not mentioning any industry, but there's a fusion with a plate system there. So I think you've all done a variety of some of these cases, or at least seen them, heard about them, and they all have their own indications. So this is a volunteer patient that I had. She was excited to be presented in front of you guys, so you're making her happy right now. These are her pre-op images, AP oblique and lateral. And you see the classic changes, the subchondral sclerosis, lack of the joint space, lateral projection, you see the dorsal flag. She's 64 years old and she's had a bump on the top of her toes for years. She stated that she had at least 2 previous steroid injections by other docs. And now she says a callus under the second metatarsal head and she can't even wear any shoes. Although she did come in with shoes, so that's kind of an overstatement. So let's walk you through this case. And when you consider, the first thing you have to consider is incision planning. One of the little tips that I would offer is that you want to shift the midline dorsal incision slightly distal because more of your work is done on the phalangeal side. Head osteotomies, you'd want to shift it more proximally. And I place my incision midline between the neurovascular bundle and the extensor tendon. One of the nice things about being a residency director is you can just bark orders and you can have really talented residents do really good foot surgery for you. After the incision, the next step is the soft tissue dissection and the base resection. When considering taking the base out, there's certain considerations that you should think about. One of the things is when you make your cut with your sagittal saw, you can actually correct the position of the hallux by how you angle it. When I dissect the base out, one of my favorite instruments is a crown and collar scissors. It's a very stubby, stout scissors with a slight curve. You'll see a picture of it in a minute. And you can use it to resect the soft tissues at the bone and the soft tissue junction. Of course, one of the things you want to be careful of is the flexor tendon. I always caution residents, I don't like them using a 15 blade down there because I have, with the help of a resident, resected inadvertently the flexor tendon at least twice. Then you also want to dial in the amount of bone you're taking out so that you can decompress the joint. And by doing this, you may eliminate the need for a Z lengthening of that tendon. I would offer that no matter what kind of bunionectomy you're doing, you should consider whether or not your hallux extensor tendon is tight, because I think that's one of the biggest reasons for recurrence and continued pain afterwards, if it's not addressed. Here's the intraoperative photos of the resection of the base, and there's a nice photo of the crown and collar scissors. When I do these, residents and scrub techs always want to hand me an Alice or a bone clamp or a towel clamp to grab the base. And I always find that's problematic because a lot of times the base will fracture and then you'll be chasing pieces of the phalanx instead of just taking out in one piece. So that's why I like to use a Brown Adson and I grasp the base on the medial side and try to move it laterally, and then use the crown and collar scissors on the other side. So by toggling back and forth, you can get a nice removal of the phalanx in one piece and spare the flexor tendon. After the base is removed, the next step is you want to put in the sizer and use the center punch. Now you're not locked into the size that you think you might need at this point, because you can change it later, which I'll speak about. But when you place the sizer in, you want to estimate that there's a little bit of overhang, 1 to 2 millimeters on either side. Once you put your sizer in, use a center punch. You don't need a mallet with this. You can just push it in manually. All of the sizes are concentric, so even if you end up changing the size later on, the center punch hole will be true on any of the sizes. This is another little, this was actually named after a resident. I won't name his name. Casey's on this this call tonight, but this we'll just call it the resident drape. I recommend taking one of the towels and towel clamping it to the drapes, and that prevents you from losing a rather expensive implant on the floor of the OR. And we've actually saved an implant a couple of times with this little trampoline. Okay, so once you have your center punch hole in place, you select your trial that you use from the sizer, that pick a size, one of the 5 sizes, and place it in. The photo on the right-hand side is the sizer in place. Remember, it's not as polished as the true implant, but one of the things I do like to do is check the range of motion at this point. This is another one of the little tips or pearls. And make sure that you're not catching on the shape of the first metatarsal head. You want a decent range of motion intraoperatively, even with the sizer. And then, of course, you take a fluoro intra-op, and you want to assess a couple of things. Is the implant the right size? Is there a millimeter or 2 of implant on either side? And is the implant centered down the proximal phalanx? In this case, we actually did remove the trial, and we took a little more bone off medially so that the implant stem was a little more midline in this patient. So we step back. I asked the residents, is the position of the hallux corrected? Do you want to take any more bone out? Is the range of motion adequate with even just the trial? Do you feel like it's decompressed enough? Is there still a tight extensor tendon? If you're not spot on, this is where it's worth it to just take it out, remove the trial, adjust whatever you want, take out more bone with the sagittal saw, and then put the trial back in again so that you're happy with it when you put the final implant in. The next step in the process is a broach. A lot of the patients don't have great bone quality, although there's the occasional ones that have very dense bone. So with the broach, it can either be inserted manually, or you can use a mallet to insert the broach. And here's where I recommend that you stop, leave the broach in, and take a lateral fluoro. By doing that, you'll make sure that your broach and subsequently your implant stem is not banging against the plantar cortex of the phalanx. I've seen that happen before. It prevents the implant from sitting in completely, and everybody gets frustrated. And when you look at it, you realize that there's a curve to the bottom of the phalanx, and you've actually contacted the bottom cortex. So here is, this is not a broach intraoperatively, but this gives you an idea. With the blue arrow, you can see that there is some curve on the plantar cortex of the phalanx. Patients have a different amount of curve, but it's very easy when you're working in a hole to have a little more bone resected dorsally and a little less plantally, and therefore the trial and the broach is directed at the plantar cortex. If that's the case, then you want to rebroach so that the broach is parallel to the dorsal cortex. and then your implant will sit nicely in and you'll be happy with your intraoperative fluoro. So you pick the size. Remember, there's 5 sizes that you can pick for. You tamp if you need it. I have only used the smaller of the nylon heads. There's 2 sizes available in the kit, but the smaller seems to work well for me. Remember, at this point, to have the resident towel spread out, so in case it slips out of your hand, it is caught by the drape, and then you want to confirm with the fluoro once again. So what are some of the advantages to a Keller with an implant or Hemi implant? Well, I would offer that even not rushing, there's decreased OR time. And this is showing off my second-year resident. Skin to skin, it was 34 minutes, and that was with taking pictures and really being careful. It's a really quicker procedure than some of the other things we talked about. I tell my patients, even the day of surgery, post-op day number 1, to begin passive range of motion of that great toe. All the structures on the plantar surface of the first MPJ have tightened up for all the years that it didn't bend. So you want to try to increase the range of motion right away. Of course, you're not doing fusion, so there's no chance of a non-union. You have a quicker recovery time than some of the other procedures that I mentioned early on as alternatives. If a patient has poor density and you don't want to do a fusion, I have done these before in patients that don't have great bone stock. And if it fails, preoperatively, I tell patients, if for any reason we need to take the implant out, it can be converted to a Keller, and you don't resect so much bone that you couldn't fuse it if needed. So there is bailout procedures, telling patients ahead of time what to expect. You'll have an improved range of motion. It won't be possibly as much as your other foot, but it will be pain-free, which is what they want. And women, I usually tell them they can usually wear up to a 2-inch heel without any problem. What are some of the disadvantages? Well, there is the possibility with any kind of implantation, and this is not just Hemi implants, that they may have a metal allergy. Remember, early on in the presentation, I said this is available in a titanium implant. I asked women, and I guess men too, but mostly women, do they have a problem with, quote, cheap jewelry? If that's the case, I'll usually ask for to swap the stainless steel out for a titanium. Interestingly, this patient came in 2 weeks ago. I had done an implant about 8 years ago, felt I sized it properly, and you can see very clearly there's bony overgrowth here, more on the plantar side, a little bit dorsally. She still was better than she was pre-op from the original procedure, but she was having some plantar pain. I offered her to remove the implant. She said, oh, no, because she had one on the other side that she loves. The plan is just to go in and do a cleanup, but there is other alternatives. You could just leave this as a straight Keller and interpose some of the patient's soft tissue in between, or you could still fuse it at this point. Another disadvantage is, I think this procedure is kind of poo-pooed by the surgical community. Again, the podiatric world is kind of trendy, and people do things that are, I think podiatry is early adopters in general. And I think this is not one of the darling procedures right now. But I will tell you that I have a lot of very happy patients, and it's a tried and true procedure in my hands, and I think in a lot of other people's hands too. So one of the things that I also insist on is, because I do that early range of motion, I have a very specific way I like the dressing. I like it cut so that I can keep the hallux free and begin range of motion again immediately post-operatively. If you bind all the toes together, you can't do that, so I do cut the adaptic.
Great, thanks so much, Dr. Adams. A couple of the questions that are coming in. First one, what percentage of your patients do you consider candidates for hemiarthroplasty?
So I assume that question means candidates out of Hallux Limitus patients. And I would say in my hands, possibly 50%. because there are a lot of people that I present a fusion to, and for some reason that word fusion, they really are afraid of the word fusion. They say, "You mean I won't be able to bend my toe again?" And I have to explain to them, yes, but we'll take your pain away. So fusion is a possibility. And I don't do too many straight Kellers. I do it for a certain small portion of the people who have Hallux limitus, but I would say maybe 50%. And I hadn't thought about that before, so just guessing.
Great, thank you. Another question on some of the surgical pearls. If your broach isn't inserted perfectly, do you have any ideas or any thoughts on straightening the implant out without having to rebroach or recut?
So I think you're obligated to rebroach or recut, either one. I can't imagine it because it's a press fit. There's really no wiggle room to change it. You wouldn't want the stem to be able to move around in the proximal phalanx. So I think you're really obligated to. It's not a big time consuming procedure. I carefully use a freer. I remove it and then rebroach again. You can move the whole broach more dorsally. And if you feel like you broach too much, you can take a little piece of the phalanx that you've just resected off the back table and pack it in there to make sure the stem sits very nicely. So I would say you're obligated to rebroach.
Thank you, excellent. Your preference between the two options of implants, porous coated or non-porous coated?
At this point, I use all porous coated. I think that there's no reason not to, and I use it for better stability of the implant, and I use all of the porous ones.
Okay, perfect. You touched on it in the presentation briefly, but just kind of to reiterate, you always recommend oversizing the implant by approximately how much?
I would say 1 to 2 millimeters is what I do.
Perfect. Here's another question that just came in. What benefits do you feel the implant offers over arthrodesis?
I think I touched on that a little bit, but I think patients like having the ability to bend their big toe. If you have a successful arthrodesis, obviously you have zero motion and you're locked into a certain heel height for women. And I think the key with early range of motion is they have a pain-free range of motion and have the ability to ambulate more sports. And I would prefer to have my patients have a range of motion rather than having an arthrodesis, if possible. And not everybody is a candidate.
Well, I think we're good. Dr. Adams, I'd like to thank you for sharing some knowledge this evening. We appreciate your time, and we appreciate everyone's time that logged on tonight.